So today we're going to be discussing co-occurring substance use disorders and mental illness, an introduction to this topic. These slides were prepared really by Dr. Bott. I'm going to give him credit for them, but we've been presenting them and contributing together. We have no disclosures. The learning objectives by the end of the didactic are to appreciate how to differentiate between substance-induced psychiatric illness and independent psychiatric illness, to learn the comorbidities between substance use disorder and various psychiatric illnesses, and to construct a treatment approach for dual diagnoses for patients with these and opioid use disorder. So we're going to start by looking at some definitions and epidemiology. And this data is from the NSDUS survey from 2016, so a few years back, and also just to note that this survey doesn't represent all populations in the US, and specifically sometimes populations that are more have increasingly been affected by substance use disorders, such as incarcerated individuals. So these are underrepresentation in terms of the numbers, but just to give you a sense of it, you can see here the past year substance use disorder and mental illness in adults in the US, that you can see the overlap between the two of 8.2 million. And then when we look at severe serious mental illness and substance use disorder, the overlap here of 2.6 million individuals. And over here, again, we see substance use disorder alone. And over here in red, the serious mental illness alone. So what we know is that substance use disorders increase the odds that someone will have an Axis 1 diagnosis. And likewise, someone who has an Axis 1 diagnosis have an increased odds ratio of having a substance use disorder. And also we know that substance use disorders, if someone has one, the odds ratio is increased for having an additional substance use disorder. We see that people with substance use disorders showed a 4.5 times greater risk to suffer comorbid psychiatric condition. And likewise, those with a psychiatric disorder showed a 4.5 times greater risk to suffer from substance use disorder. So this goes both ways equally. And schizophrenia, schizoaffective, and anxiety disorders were the most prevalent of those psychiatric disorders noted. A large Danish study from back published in 2016 showed that looked at a wide array of psychiatric conditions ranging from depression to bipolar to schizophrenia, showed a varying percentage, but relatively high, of prevalence of any lifetime substance use disorder. So at the top of the list, again, was schizophrenia at 37%, down to 11% for OCD. And notably, alcohol use disorder was the dominant substance use disorder in each psychiatric category. Also of note, most of the patients with substance use disorders, they were more often men, had fewer years of formal education, more often received disability pensions, and died due to unnatural causes. Here are some of the consequences associated with concurrent substance use and psychiatric conditions. So you can see that at the top of the list, there are more psychiatric hospitalizations. I won't read these all out, but you can see that pretty much across the board, there's an increase in pretty much different societal markers, such as comorbidities, medical comorbidities, violence, crime, and then also homelessness and adherence to treatment. So how do we go about assessment for co-occurring conditions? So how we're going to go about it will differ for for someone who's presenting in a state of intoxication, we need to address emergent concerns. So we're going to be screening for suicidality and homicidality. Again, reviewing that vital signs are stable and attending to all of the withdrawal management and medical symptoms that are presenting. So we're not going to be doing a deep psychiatric evaluation in a patient who presents intoxicated, and we'll wait until they are sober. So oftentimes we'll see them back, at least in our walk-in setting, in the next day, the next 2 days, and at that point be able to perform more of a psychiatric assessment once we are assessing their initial stability and treating that. So how do we distinguish between independent versus substance-induced psychiatric illness? And the substance-induced, it usually we see these resolve, the symptoms resolve with sustained abstinence from the substance. Not always, but typically they will, because the psychiatric illness in these cases would be related to the use of the substance. Likewise, the independent psychiatric illness would be present during the times of abstinence, so wouldn't necessarily be related to the substance. But notably, there's no defined time period to differentiate the disorders. Oftentimes we learned, waiting till they were off of the substance for a month, but there's really, that's largely arbitrary. There's really not a well-defined period of time. Substance-induced disorders, we see the symptoms only when the patients are using or have recently used the substances typically. The symptoms are related, and we'll go over more specifically for each substance what this looks like, to intoxication state, withdrawal, or other aspects of use. And we often see that onset or offset of symptoms will be preceded by increases or decreases in the substance. So the history really is key here. And our goals in these situations is to work with our patient to remain off the substance and then be able to reevaluate them to see how they've responded and what their symptoms look like in terms of compared with their initial presentation, to see if it does indeed seem that they continue to experience a psychiatric condition. Whereas with the independent disorders, the symptoms occur when they're not using the psychoactive substances or with steady use without change in the amount of type. I think family history can be very important here. Also, because it's difficult sometimes to discern this just by being off the substance for a certain amount of time, in the case, and this can be hard, but in the case that someone's able to actually recall, or if they have other historians there who can recall that these symptoms were present prior to initiation of substance at all, that can also be very helpful in terms of differentiating. And the goal here is going to be cessation of the substance use and treatment of the psychiatric symptoms as well. So again, some pearls from this. Family history can be really helpful. The initial symptom onset, again, pre or post the use of substances, can be very helpful. And what happens with symptoms during periods of abstinence. And then observing what happens as we treat. I'm just going to check the chat here. Yes, thank you. Thanks, Dr. Bott. I'll keep going with the slides just in the sake because of timing, but I appreciate you addressing the chat. So here you can see a table. I won't read through it, but again, differentiating clinical characteristics that help us distinguish primary mental disorder versus substance-induced. Again, you can kind of see here in the primary that we see the symptoms still persist during abstinence. There's a relapsing course of the psychiatric disorder. We see that family history, perhaps personal history, and later substance use onset we may see as well. And then with the substance-induced disorder, again, we'll continue to see this association between the onset of psychiatric disorder and this consumption of the substance. And notably here, we may see earlier substance use onset. So we're just going to turn now to going briefly through some slides that look at each substance. And mainly this is, you can kind of see in red on each of these slides for the intoxication and for the withdrawal state. You can see that the symptoms that are in, or the signs that you see that are listed in red, you would see from both use of the substance and from psychiatric, perhaps from psychiatric illness. However, in blue, these signs would not be found from psychiatric illness. For instance, intoxication with alcohol, we would not expect, we would expect mood lability, we would not expect slurred speech from a psychiatric comorbidity. So if you are seeing things such as unsteady gait, impaired memory, stupor, certainly these would be both very worrisome and also attributed to the substance as opposed to psychiatric illness. Same with withdrawal. For alcohol, we expect to see anxiety, perhaps even auditory hallucinations. But the withdrawal state, which, as you know, can be very dangerous and at times lethal, can involve these signs listed in blue. For cocaine or other stimulants in the intoxication state, along with co-occurring psychiatric illness may also cause anxiety, anger, hypervigilance. However, we wouldn't expect, except from the substance alone, to see these symptoms that are listed in blue. And for the sake of time, I'm not going to read all of these. I'm just going to let you kind of look through them here. With the withdrawal state, however, for cocaine, really we can see all of these things, both with other underlying comorbidities, dysphoria, fatigue, insomnia, etc. Likewise, for cannabis in the intoxication state, we may see these things as well with other psychiatric illnesses. However, as listed in red, however, in blue, this would be from the intoxication state alone, such as tachycardia or conjunctival injection. In the withdrawal state from cannabis and from psychiatric illness, we may see those listed in red. And again, in blue, we would expect for us just from the withdrawal of cannabis alone, the headaches, shakiness, etc. Also with opioids in the intoxication state, in red, you may expect to see these things listed in red, as well as with in the case of psychiatric comorbidities. However, in blue, the meiosis, slurred speech, drowsiness would be from opioid intoxication alone. And the withdrawal state, likewise, you can see in red some of what you might expect those symptoms to occur, but in blue, just from the opioid withdrawal alone, would you see nausea, vomiting, lacrimation, etc. And with nicotine, we're really just talking here about the withdrawal state, lots of symptoms that are very uncomfortable for patients, really just the bradycardia. Could be just contributed to nicotine withdrawal alone. So what are some things to consider for treatment? And I believe this slide is a picture that our colleague, Dr. Romo, also likes to show in his dual diagnosis talk. When we think of treatment in terms of keeping the whole boat afloat, and if there's going to be two holes in one boat, in one ship, it doesn't help to just treat one. To keep the ship afloat, we need to treat both as concurrently as we can. So it was, again, in terms of treatment, it was previously thought that, we're not going to treat the co-occurring psychiatric condition unless we have at least 6 months of sobriety, but fortunately that is not the standard of care that would neglect to treat someone adequately. This was revised to having at least 1 month of sobriety. Really, dual diagnosis must be treated simultaneously, not in sequence. And so whether in the community at large or in a psychiatric or a addiction treatment center, it's really crucial to treat both. And aside from that initial slide explaining that we want to treat make sure that someone's not presenting intoxicated so that we can do an appropriate evaluation. Once they are able to be assessed thoroughly, then we can offer treatment for both. And also it's important to remember that substance use does not equal substance use disorder. So sometimes if we see that someone's positive every now and then, perhaps for a stimulant, they may not meet criteria actually for stimulant use disorder. And so this is an important thing too, because to remember, just because sometimes people may be more hesitant to treat psychiatric illness if they are considering treating both a substance use disorder, and even though we want to encourage treatment of both, it's possible they don't even have the substance use disorder, and so that's an important thing to also determine at first. So steps to treatment, as with mental illness, psychiatric illness alone, you can consider psychotherapy as first-line treatment, also in patients with substance use disorder and who have less severe depression or anxiety. And then step 2, excuse me, considering pharmacotherapy, again, waiting until they're sober and then considering that it may be first line for many patients if they present with more severe symptoms rather than waiting. So in general, depression and anxiety are very common at treatment entry when someone's presenting for treatment of substance use disorder. However, those symptoms may resolve within a few days of stable treatment. But the symptoms that persist beyond that acute intoxication and withdrawal state really should be treated with medication in addition to if therapy is being offered and is available as well. So for example, with our SSRI class of medication, that is many times first line. And importantly, patients who are treated with medication for opioid use disorder, otherwise also known as MAT, respond to medications for depression and anxiety at rates that are similar to those who do not have opioid use disorder. So just as important to offer these. Very important to avoid addictive medications if possible, so such as benzodiazepine and stimulants, and monitor carefully, especially in the case that someone is appearing to need one of those potentially addictive medications. We want to monitor them very closely. For primary care, here's a list of some recommended medications for depression, our first line SSRI, and then our SNRIs and bupropion. For GAD, we're also looking at our SNRI, SSRIs. Buspirone may be of some effect, and escitalopram also has quite good effect as well, and some less side effects than other medications potentially. Also for panic, SSRIs would be recommended. Social anxiety, if not contraindicated, paroxetine. PTSD, also our SSRIs, venlafaxine and prazosin has shown some benefit as well. And for bipolar disorder, may consider valproate. So again, just returning to some of that data that we looked at, this is looking at the treatment that's offered. You can see that it is still, this is also 2016 data, but still quite low. So of the 8.2 million adults who have that co-occurring mental illness and substance use disorder, at least half are not offered medication treatment. And 38% are offered mental health services only. And just about 7% are offered mental health services and the substance use treatment. Similarly, for our patients with the severe serious mental illness and substance use disorder of those 2.6 million adults. We see that about half are offered mental health services only, 34% do not receive treatment, and specialty substance use treatment only at 2%, and mental health and specialty substance use treatment at 12%. So we have a long way to go. We recommend, in line with SAMHSA, an integrated approach to treatment. So rather than sequential or parallel approach, an integrated approach to treating co-occurring mental and substance use disorders really involves collaboration across disciplines and is patient-centered and aligns with their goals. With frequent check-ins, I would say too, sometimes patients' goals may change from the day that they present to as they're going through treatment. So continuing to reassess those. And integrated treatments are associated with lower costs and better outcomes. So we see reduced substance use, we see improved psychiatric symptoms and functioning, decreased hospitalization, increased housing stability, fewer arrests, and improved quality of life. So I'm going to stop the share and see what questions or comments people have.